Good evening and welcome to our webinar. My name is Celeste and I will be your host for tonight. I do understand that we do have some load shedding around the country, so please rest assured that the link of the webinar will be shared afterwards with everyone, so you won't have to miss any of the exciting things that we do have in store for you tonight. Our previous webinar with Dr. Rocio earlier in the year was extremely successful, where she introduced the Riva Star with the Strontium modified glass Ionomers and the SMART technique. If you missed this webinar, please send us an email if you would like the link to also rewatch that webinar, which links perfectly to what Doctor will be discussing with us tonight. With all the talk around the role that STF can play in minimal invasive treatments and caries and reduction of hypersensitivity, it's no wonder that Riva Star has become the star of the year so far. So please help me to welcome Dr. Rocio back to the South African stage. Doctor, thank you so much for joining us again tonight. Welcome back.
Thank you, Celeste. Thank you for the invitation. I'm so happy to be here this afternoon with South Africa and to talk about minimal invasive dentistry, about SDF, and this new generation of glass ionomers. So I'm so happy to be here with you again. Thank you so much.
Wonderful. Thank you. So, Doctor, I'll stay on stage till you've shared your presentation, then I can confirm everything is working well. Perfect. I can see your presentation.
Okay, it's perfect?
Yeah, it's sharing full screen.
Great. So I'm ready for start? You told me?
Yes.
Yes?
Yes,
So,
you can start. Thank you so much, Doctor.
Thank you so much. Okay, so I'm going to start to talk to you about this item that it's the minimal invasive dentistry and talk a little bit about biomimetic in dental caries and in molar incisor hypermineralization. I love to talk about this because it's my passion to talk about minimal invasive treatments and biomimetic. So first, I will introduce to me. I am pediatric dentistry in University Peruana Cayetano Heredia. I am professor of postdoctoral pediatric dentistry in Peru. I am director of Special Smiles by Special Olympics. I did internship in pediatric dentistry program in University of California, San Francisco. I have 3 awards for best research about medical and dentistry science in Hipólito Unanue Foundation, Peru. I am international speaker on biomimetic and minimal invasive dentistry in Europe, South Africa, USA, Latin American, and Caribbean. And I was invited for a lecture in the Royal Academy of Medicines and Science of Galicia, Spain. So this is a little bit. And what is going to be the topics that we are going to talk today? The topics are 8. The first one is what means minimal invasive dentistry, NoDental Aerosols. We are going to talk about selective remove of caries tissue. When we are going to do selective remove and when we are not going to do a selective removal of caries tissue. Then I will talk about what kind of the material work perfect in minimal invasive dentistry. And of course is SDF, silver diamond fluoride. And we're going to talk that both techniques, non-restorative, that it's called cavity control, and restorative cavity in patent fissures, in enamel, and in dentin, this technique that's called SMART technique. And I will talk then about biomimetic in dentistry, how is bio-remineralization, and how bio-remineralization is different than remineralization. And then I will talk about biomimetic biomaterials in caries and molar incisor hypomineralization. And the last item that I will talk, it's about the new generation of glass ionomers with the Strontium for dental caries and molar incisor hypomineralization. I love to start with this presentation telling that knowledge, it's power. And it's important because we need to know what is happening in the dental tissues, that it's different enamel lesions, that it's different than dentin lesions, and it's different than molar incisor hypomineralizations. So we need to know what's happening, histology, no? And to know the different kinds of materials for this, for the treatment in these different situations. So if we know, we are going to have the power, and we are going to talk about these new materials that are bioactive biomaterials. So we are going to be ready for this new generation, especially in pediatric dentistry. Okay, what means minimal invasive dentistry? When we listened about minimal invasive dentistry, sometimes said, okay, no drills. It's the first thing that we have on mind when we listen minimal invasive dentistry. So no drills, it's perfect because right now we are so scary about the COVID, and we are so careful that don't use aerosols, don't use drills, and it's perfect minimal invasive dentistry, okay? Because what happened when we are using aerosols? This is what is happening. Particles, saliva, blood, look all the kind of bacteria and virus there is around us when we are using aerosols. So this is why everybody, all the associations, dental associations, recommendation is please try to don't use aerosols. And especially if you want to use it, use face shields. But if you don't want to cover your face and use all these tools for protection and get out the face shields, maybe it's better if you use or if you do your treatment with minimal invasive dentistry. But minimal invasive dentistry, it's not only don't use aerosols, it's more than. It's the detection of the early caries lesion. This is so important. Then the prevention and the risk of the patient. The minimal intervention, caries arrest, remineralization of the lesion, and bio-remineralization of the lesion. So first, early diagnostic. To do a good early diagnostic, please use loops. It's important because sometimes you can confuse if this patent fissure is with caries or not, or so you need to know exactly what is happening. Because if we have, for example, that we don't have, of course, microscopy, no, that shows to you what is happening, no, in this patent fissure that is this mineralization. So try to do a good diagnostic, especially in these caries that is in enamel, these early caries lesions. And the other problem is when you want the diagnostic in the proximal caries. Sometimes you need X-rays, especially the Baldwin's X-rays, for the early diagnostic of these lesions. Okay, and what is another important to early diagnostic? The white spots. This first step of the caries, that is the white spot, and another kind of enamel lesions that are fluorosis or molar incisor hypomineralization. When we have a caries in dentin, it's so easy for the diagnostic. Sometimes the mother of the kids calls to you and said, "Doctor, my kid is with the caries. I am brushing the teeth and I'm looking at caries." Okay, this is easy. The most important thing in minimal invasive dentistry is try to do it an early diagnostic. So what is the other important point in minimal invasive dentistry? The minimal intervention. And you have two kinds of minimal intervention: no removal of the lesions and removal the selective remove the lesions. So first I will going to talk about the no removal lesion, and in which case you won't remove this lesion. For example, if you have caries lesions in enamel that is the early lesions, you don't need to remove the lesions. You only need to clean, no? To clean the lesion, but don't remove the lesions. And you can do it a no restorative control, for example, with silver diamond fluoride. And you will have great results, okay? And what is happening, for example, in this and other early caries lesions in first permanent molars, we can do it, no restorative cavity control, but in this case, I did with this new generation of glass ionomers with a strontium. Okay, look here, I not need to remove the lesions. What another case? For example, proximal caries, but proximal caries in enamel, not in dentin. I want to show you this second primary molar. Look here, its the lesion is in enamel, and 6 months later, using SDF, I never remove the lesion, only I applies the SDF, and look here, remineralization. So it's perfect for these lesions, proximal lesions, using the SDF, and you don't need to remove the lesion. What another kinds of cases? For example, the white spots. In this case, it's better to have good results, use biomimetic biomaterials. For example, in this case, I used the nanohydroxyapatite. Look, this is another case of white spot. This after orthodontic treatment. Look here, the white spots around the braces. No, so look that with biomimetic bioremineralization with nanohydroxyapatite, I had these better results. And why I have these better results? Because when we are using these bioactive biomaterials that it's our new, when I am talking to you for biomimetic, look here, this is the white spot. You have 4 zones. The surface zone, the mineral loss, it's only 5 to 10%. But the problem is in the body of the lesion, that the mineral loss is 18 to 50%. So what place, what zone we need to give more minerals, more calcium and phosphate minerals, the body of the lesion. So this is important because when we are using a fluoride varnish, we are only working in the surface zone, but when we use bioactive biomaterials, for example, nanohydroxyapatite, we are working in the body of the lesion. So it's why we have good results in this protocol that I'm doing, that it's biomimetic and microabrasion and Bio-Remineralization with nanohydroxyapatite. You look this fluorosis 4 weeks after the treatment, looks better. It's the same with this another case. And with MIH, we are going to have better results in these several cases. Look here. So right now, this surface, this enamel surface, is ready and have a good adhesion for the composite, for the resins, and you will have great results. This is all doing without removal deletion. In these cases, you can do it no removal deletions. The other minimal intervention is a selective removal. You can do it as selective removal, for example, in enamel, using only spoon excavators. You remove the lesion and then you can use it, for example, SDF or these glass Ionomers with a Strontium, that is the new generation. And the other selective removal is when you have dentin lesions, dentin caries lesions. So you are listen so much about the selective removal of caries tissue. And a lot of systematic reviews said it's good to do the selective removal because you are not going to have risk for pulp exposure. So it's great to do that. So I'm going to talk right now about the selective removal caries tissue. Okay, when we have a dentin caries, we have two zones, the soft zone and the firm zone. What happened in the soft zone? We are going to have a necrotic zone, contaminate, okay? But in the firm zone, we're going to have a desmineralization zone, but not contaminate. And we are going to talk. The soft zone, it's called infective dentin. And we need to remove this infective dentin because it's irreversible denature. We have a lot of bacteria here and the collagen is desnaturalization there. So we need to remove all the infective dentin, okay? This zone, you need to remove it because if you don't remove it and you use it, for example, a remineralization material, the remineralization materials need a collagen that it's be healthy. You don't need a denatured collagen because the denatured collagen it's not going to help to the remineralization. So when you have caries in dentin, you need to remove the infective dentin. So here you have sometimes the problems and said, I remove all the infective dentin. I am in defective dentin. So look here, the difference of the colors. The infective dentin, it's more brown, and the effective dentin, it's light brown. So you can check that. So the effective dentin, it's a bio-friendly tissue. It's great because you don't have bacteria there. The collagen, it's healthy. It's perfect for health for the remineralization. So it's important. Remove so well the infective dentin. So we need special tools for selective removal. We have 4 kinds of tools. One's more better than one's. So we have the rotary cutting instruments, the caries excavation and fluorescence technology, hand excavator, and the chemical mechanical for selective removal dentin caries. So when we have this rotary for selective remove, we have sometimes the risk that maybe remove not only the infective dentin, maybe we are removing the affected dentin. We don't have control. So right now we have three different kinds of rotary. The cardboard that you don't have, okay, the control, the ceramic that it's so hard, and the polymeric that it's called Smart Burst 2. This is good for selective removal because are so hard that the same as the sound dentin, and it's more hard than the soft dentin, this dentin that is the infective dentin. So it's important when you are thinking to use these smart boards, it's important, it's really, really, really important and to use micro angles that are slow speedy. It's better it's 2500 RPM. It's going to be good because what happened with this smart boards, if it's high speedy, the problem it looks what is going to happen with your smart boards. It's a high speedy and you are going to have problems with the smart boards. So pay too much attention if you want to use it, that use micro angle that be low speedy. Okay, this is these smart boards. They are so great for removal infective caries, and this is when you finish remove the infective caries. Okay, we have another tool that is the fluorescence tools. These fluorescence, when you light the lesions and you have bacteria, the light will be red. And if you don't have bacteria in the lesion, the light will be green. So I will show you how it's working. Okay, it's why I'm explaining to us that you have the caries lesion in dentin and bacterials, the light is red, so you can remove it. And then when you remove all the infective dentin and you don't have bacteria, the light is green. So this is another tool for helps the selective remove caries. The problem of this is that sometimes the fluorescence don't helps to you well, because in affective dentin sometimes you can find a little bit rest of bacteria, so maybe can show you red light and you start to remove and it's not necessary. So it's a good tool, but it's not the best tool. Another tool is the hand remove, the classic hand remove with the spoon excavators. here it's important to don't try to use this kind of spoon excavator that are going to remove so much, and it's you need to push, and when you are pushing and removing the infected dentin, maybe you are removing the affected dentin. So in this case, it's better to use these spoon excavators that are more are not cutting so much. Look here. Look, these kinds of special to remove the walls. Look here. With this, you can remove perfect the walls. But when we are reading this systematics review that asks what kind of removal caries the patients accepted more, they said the most accepted is the chemical mechanical removal caries. And we are talking about Briggs 3000, that is a new technology of enzymatical chemical mechanical selective remove. This enzymatic, it's so smart because it's only remove the infective dentin, and it's not going to remove to you the affective dentin. So if you compare doing only hand remove with the dental spoon, that you need sometimes to do more push and give more power for remove, and you compare using this enzymatic removal, it's going to be better and you will have better results in your selective removal caries. So let's check this case. This is a patient of 6 years old. The diagnostic is reversible pulpitis of this first primary molar, this upper first primary molar. And what kind of treatment I will do with this patient? I'm going to do minimal invasive dentistry. No, I don't need anesthesia. I'm going to use the Briggs 3000 for selective remove. Then I will do a direct pulp capping with a bioactive biomaterial that it's now putty. And then I will restorative with the Riva Light Cure high viscosity, that is this new generation of glass ionomers with Strontium. Let's check. It's so easier, no anesthesia. I apply for 2 minutes and the patient is comfortable during this applies. Then I start to remove the infected dentin, and I don't need to do any pressure when I am removing, so the patient don't have pain when I am removing. When I finish to remove, of course, I have a pulp exposure, but the patient didn't have any pain in this treatment. I asked to the patient if he feels comfortable, if he doesn't have any pain, and the patient said that everything is okay.
Todo súper bien.
So after removal and for the treatment of this pulp exposure, I did a directal pulp capping with a bioactive glass that is the nail putty, and then I did the restorative with the glass ionomer with the Strontium, that is the Riva Light Cure high viscosity. And with this Riva, I forget to use the steel crowns because resists perfect restoration of the class 2 restorations are perfect and resist the occlusion forces. So I'm not using right now the steel crowns for these proximal lesions. Okay, so it's perfect to use this kind of treatment, this selective remove, because this research said that after 2 years, if you are doing this minimal invasive treatment in caries and dentin, you're not going to have risk of doing whole pulpotomies or pulpectomies in these cases. So it's perfect to use it, this bricks 3000 for removal, and then in the case that you have pulp expulsion, use a bioactive biomaterial like NeoMT8 or Biodentine. And if you don't have a pulp expulsion, it's better to use it these glass ionomers with a strontium, like Rival Light Cure High Viscosity. So when we are ready with our effective dentine, so healthy, so what is the next step? Because we know that right now the effective dentine, it's great because the healthy collagen will help for remineralization, but we have a little problem. We are ready for remineralization, but the adhesion of the glass ionomers and composites are not well, especially these glass ionomers that are the regulars, that are these glass ionomer that doesn't have strontium. With this kind of glass ionomers, you will have a lot of problems in adhesive in the effective dentine. So why? Look this systematic review. When we are talking about ART, that this is a traumatic treatment, this a systematic review said that successful, it sometimes is good and sometimes it's not good. Look here the results. For example, in primary teeth, sometimes you have 24% of successful, and another cases you have 96% of successful. In the case of permanent teeth, you have 43% of successful in some case, and in others 98% of successful. So it's this a big difference if you have successful or not successful. So it's a big headache, no? You're not sure if your treatment we're going to have a good successful. And why? Why is this difference? It's because first, the regular glass ionomers doesn't work 100% successful in effective dentine. And why? I will explain to you. When we are in dentine, we only have hydroxyapatite 70% in dentine, okay? And the other 30% is collagen, is organic. So when we are working in the effective dentine, sometimes we have the problem that the crystals, the hydroxyapatite crystals, are not in harmony. So the pH maybe it's low because it's start acid attacks. And you lost calcium and phosphate ion. So this is demineralization. So in this case, you don't have good crystals of hydroxyapatite, you lose calcium and phosphate. And if you're thinking to use, for example, glass ionomers and think that the fluoride that is inside these glass ionomers is going to help to you for mineralization, look here. You need the calcium and phosphate to formation of fluorapatite. If you don't have calcium and phosphate in your affective dentin, you are not going to do the formation of fluorapatite. And this is the problem of the classic glass ionomers, because these classic glass ionomers depended of the calcium that you have in the affected dentin for form the fluorapatite and start the remineralization. So pay this so much attention, because sometimes you don't know if you have the perfect accounts of calcium in your affected dentin, and if this calcium we are going to interaction with the fluoride and with the fluoride and the calcium ions to form the fluorapatite crystals. So this is important to know. Why is the reason of the faults of the classic lysoiomers? They need calcium in the affected dentin. And what happened? Why the resins are not successful in affective dentin? Because in affective dentin, we have metalloproteinases. And these metalloproteinases are sleeping. But if you doing an acid attack, for example, orthophosphoric acid, this will going to wake up, and we are going to degradation the adhesive, and you are going to have problems of secondary caries. Look at this. In this case, it's the same in the X-rays. Look here. Okay. The metalloproteinas are degradation, the adhesive, and that's the reason that you have a secondary caries lesion. This study said Domenico Ricucci that for him it's not a good idea to doing selective removal and working in affective dentin. And why? Why the results are so bad in this study? It's because in this study, they used resins, composite for restoration. And this is what happened. Ineffective dentin is wake up the metalloproteinases, and these are going to do the degradation of the adhesive, and you will have secondary caries, and you're not going to have successes in your treatment. So, no resin fillings in affective dentin. And what happened in molar incisor hypomineralization? That is the new challenge for the dentist, especially for pediatric dentistry, but I think so for all the dentists. And why? Because your patients came and said, oh, I'm not so comfortable with my aesthetic, look the color of my teeth. Then you look that the enamel is so porosity that it's broken so fast, and the biofilm stay there and start caries lesion. Then the patients told to us, I have a hypersensibility, and then we have a bad adhesive in this enamel. So it's a really, really challenge for us when we are thinking in doing a treatment in molar incisor hypomineralization. So why? Why it's a headache? Because first we have an enamel deficiency in minerals, especially calcium, 20 to 25% in the surface, okay? And look here, we have the hypomineralization, broken so fast, caries lesion. And what happened in the dentin? In the dentin of a hypomineralization enamel, we are going to have more zones of interglobular dentin. The zones of interglobular dentin are slightly less mineralization. So this is a problem, because we need calcium to interaction with the fluoride and form fluorapatite for remineralization. And in these zones, we don't have. We need calcium for the adhesive with resins, and we don't have calciums for good adhesive. So this is the reason that we are not going to have good successful when we are using the regular glass ionomers or the resins. The adhesive is really bad. Look here, when you apply orthophosphoric acid to the enamel, look this disorganization, okay, in the enamel, and look the folds in the glass ionomers. So what kind of materials are so good for minimal invasive dentistry? For minimal invasive dentistry are good materials the silver diamond fluoride and bioactive biomaterials, because silver diamond fluoride helps to you for minimal intervention, caries arrest, and remineralization. And bioactive biomaterials like strontium modified in bioactive glass, like it's in this new generation of glass ionomers, it's going to help to good minimal intervention, arrest caries, remineralization, and bio-remineralization. So let's start to talk first about the SDF and the potassium iodide. So we are listened in the few years more about SDF, and why? Because in the 2050 FDA approved the SDF in the United States, in the USA, and said that it's a good desensitivity material. I had the opportunity to work in this study with Dr. Peter Milgram, and this study helps to the FDA to approve the SDF in the United States. So this study we did this study in adults that have problems with caries class 5 and have a lot of sensitive. And in this study, we applied the SDF, and in only 24 hours, the patients didn't have sensibility. And after 7 days, it stayed so well, the control of the sensitive of these cases. Okay, so what is the composition of the silver diamond fluoride? The composition is silver ions, amine, and fluoride. If we compare silver diamond fluoride with a fluor varnish, look at the different counts of fluoride. In SDF, we have 44,080 ppms, and in fluoride varnish, 22,600 ppm. So we have more accounts of fluoride in SDF. So that's the reason that we have good results. And this is the reason why the Academy of Dental, the American Dental Academy, suggests that the SDF is the best material for non-restorative treatments. It's better than fluoride, it's better than Recaldent, and recommending too for the patients that are receiving chemotherapy or radiotherapy. It's good that the treatment of the early lesions do it with SDF, and we control these caries and don't have risk of future infections. So let's check this. This is the SDF non-restorative, the non-restorative cavity control. We have a patient of 2 years old, and look here, the caries is only in enamel. You don't need to remove the lesion, only clean the biofilm. You only need to clean the biofilm and apply the SDF. And look here the results after 2-month follow-up. Perfect remineralization in this enamel. Why? Because it's a good penetration. It's a good penetration of the silver that it's going to kill all the bacterials. And it's a good penetration of the fluoride. In this case, the fluoride is not going to only penetration the surface zone. It's going to penetrate the body of the lesion. This is the difference of fluor varnish and SDF. It's good for remineralization, and don't worry about the stain. Why? Because right now we have the Ki, that it's the potassium iodide, that will reduce the stain. Look here, in this case, this caries impedance fissure. It's not so dark, and if you have sounds impedance fissures, it's not going to stain and reduce the staining in dentin caries. Look here, how good is the penetration? We have this case, caries in enamel. We use it, the SDF, and SDF, the penetration, it's perfect in pit and fissures. So what we need for a good applies? First, we need a good micro brush for applies the SDF. Okay, we only need 1 drop for applies, and then we are going to use 1 drop of Ka, but 1 drop in 2 times. Okay, so I will show you this video that you need first to prepare the patient to receive the SDF, because the SDF, if you maybe the patient move a little bit, you can stain around the lips of the patients. So you need to cover with a butter, with a Vaseline, to don't have any risk of stain the skin of the patient. Look here. So we are ready for applies the SDF, and we are not going to have this kind of problems if you are not careful. No, and look here is a stain. So this is important to cover the patients. So when you are ready, first 1 drop of the SDF. Look here how easy it is to apply. After applies, you need to put a little air for more penetration of the SDF, and immediately after 1 minute, you are going to apply the Ki to reduce the stainless of this SDF. So you are going to use another micro brush, 1 drop of Ki, and apply. Look how easy it is. So this, you're going to do it 2 times. You're going to apply the Ki 2 times. And then after that, you're going to use the water to clean everything. And everything is ready. It's so easier. It's so easier. So how are we going to apply, for example, for the proximal caries? We have this case. And look here. The caries is in enamel. So I decide to use it SDF for this proximal enamel caries. And look at the follow-up of 6 months. Great results. So how I'm going to do it this? For example, I have another case with these lesions in enamel. So it's good to first use these orthodontic separators, and after use it in the next appointment, you get out and you will have this special space. So it's going to be good for you for applies the SDF. You can apply the SDF with this floss, or maybe using this micro brush that's called point. This point, it's perfect for proximal applications. Look here, and I will show you this video, how I using these points. Look here, I get out the orthodontic separators. Everything is ready for applies the SDF. Look how I am applying the SDF. It's easier than using the floss. Okay, remember, 1 drop in the lesion. Then I dry. I wait 1 minute. And after that, I'm going to use the Kai Eye. The same. I apply, remember, 2 times. These points are perfect because you know exactly that you are applying 1 drop of the Kai Eye or the SDF. So after that, you dry and then water, wash the teeth. So it's easier too to apply in proximal caries. And no restorative cavity control in dentin with SDF. It's good too. When you are indenting, it's better to remove the infective dentin. But if you are indenting so close to the enamel, maybe you can do it a no restorative control and have good results. But I suggest that when you are indenting, it's better to remove the infective dentin. The SDF, it's great the penetration in dentin. It's better than in enamel. And the penetration is to 50 to 2,000 micrometers. The other good property of the SDF is that it's going to innervate the metalloproteins. Do you remember the metalloproteins that are sleeping and wake up when have an acid attack? Okay, the SDF, the silver, is going to innervation these metalloproteins. And it's going to be good for remineralization. And look the penetration. The penetration, it's so good in the dentin. So we are going to have 2 techniques for restorative after the applies of the SDF. One we are going to be in enamel and the other in dentin, okay? So we have this last study, this last compendium that tells to you the clinical instructions for using SDF in dental caries management. And talks, that first one, it's good, for example, if you're thinking in pit and fissures treatments, it's perfect because you first are going to apply the SDF. This is in a sound enamel. You can apply the SDF and immediately you can apply the sealant and photopolymerization, and you will have great results too. In the other way, if you have these enamel early lesions, you have two options. If you want cavity control treatment, or if you want, you can apply the SDF, and after applying the SDF, you're going to use the zip bond, this universal adhesive. You're going to photopolymerization for 20 seconds and then applies a flow resin. This Aura Easy Flow, it's a really flow resin. This helps to you. And you're going to have this restorative after the place of SDF. Look here, in this case, you have the two treatments. This is SDF and flow resin, and this is only FDF. Why you use it one option or the other option? For example, if you know that your patient is not going to have maybe don't have brushing the teeth so good, you're going to have a lot of biofilms, and the patient is so lazy to brush the teeth, I prefer to use that restorative in the same appointment. But in the case of the patient, it's more careful after your instructions of daily toothbrush, and the patient is going to have responsibility, no, or the parents are going to have responsibility. Okay, you can use the cavity control. And if you're sure that your patient is going to come in 6 months for control, use the cavity control. But if you are not sure that your patient is going to come in back for the next appointment in 6 months, it's preferred to use the SDF and then the resin. Okay, if we are indenting, we are going to do the SMART technique. The SMART technique is the silver modified atraumatic restorative treatment. So in this case, is the perfect match is the SDF and the glass Ionomers for denting. And you are going to have good results. You're not going to have problems. And if you don't want to have problems that stain the glass Ionomer, use the Chi. Look here, I will show you this case. This is a little kid of 2 years old. The bad behavior, I said to the mom, I'm going to use a general anesthesia, and the mom said no. So I gave to the parents another option, that is using the SDF. And the parents said to me, okay, we prefer the SDF than the general anesthesia. So in the upper, in the maxillar, I used the SDF with a Ka, and in the lower, in the mandibular, I only use the SDF. Look the difference. No problem with the staining of the glass Ionomer. The follow-up is the same. In both cases, good results, 6-month follow-up, 18-month follow-up, so you don't have any problem. In this case, in adults, for example, if you have caries class 5 in the neck of the teeth, you can use it SDF and then applies the eye, and immediately you can apply the glass ionomers, and you will have good results. Look here, not too much paint in these patients, no too much stain. Okay, I talked that it's a great penetration of the SDF in dentin. The problem is this great penetration is that we are going to have so much careful if we are close to the pulp, because if the pen is good penetration, that sometimes this is a disadvantage, because if you are so close to the pulp, this high penetration maybe can necrotic the pulp. Look, this happened to me in this case, and when I did the open of the chamber, looks how was the penetration. This was the reason of the necrotic of the pulp. The silver in contact with the pulp, necrotic. So be careful. Please try to use it only the SDF. Think that your lesion of the dentin, it's in 3 parts. So the first part that is close to occlusal, to enamel, you can use SDF. The lesion that is in the middle, use SDF. But if the lesion is close to the pulp, please don't use SDF. Okay, we're going to talk about the other material that is great in minimal invasive dentistry. That is the bioactive biomaterials. And if I'm going to talk to you about bioactive biomaterials, I want to talk about biomimetic. What means biomimetic? Biomimetics means to mimic the nature. And what I will going to mimic the nature, I'm going to mimic in the biomineralization. What means biomineralization? Biomineralization is a process that all the tissues that are high mineralized, like the enamel, dentine, or the bones, needs the organic matrix to form the hydroxyapatite crystals. So this is why it's important the presence of the collagenous fibers, because the collagenous fibers are going to crystals the calcium and phosphate ions and form the hydroxyapatite crystals. This is why I talk to you in this presentation. Please remove the infective dentin, because infective dentin, the collagen, is desnatured, and you are not going to do never a bio-remineralization and never a remineralization. The bioactive biomaterials in medicine are used years ago with Dr. Larry Hinch in the 1969, that he developed the first class ionomers in medicines for bones. And let's listen this video.
Human beings are fragile. Accidents, injuries, traumas. The human body can regenerate itself, but sometimes it's not enough. Implants, prostheses, and substitutes are often necessary to rebuild osseous structures and help the body to regain its functionality. Bioactive glass contributes to bone growth. It can be used in a wide range of medical applications. Like here, in the case of bone filling, the material is put into the bony defect. Just a few hours after the implantation, ionic exchanges occur between body fluids and bioactive glass. a biological fixation is created between the biomaterial and host tissues, leading to a solid grip within the osseous site. This fixation becomes a silica gel and gradually mineralizes into a calcium phosphate layer. The composition and structure of this layer are identical to human bone. The fact that silica and phosphate concentrations are increased around the material causes a genetic activation, which induces a differentiation and proliferation of osteoblasts. These osteoblasts are the actors of bone remodeling. "100% synthetic, therefore 100% safe, bioactive glass is biocompatible and bioabsorbable. All its bioactivity lies in its ability to transform itself and, in the end, to become completely assimilated by hosts. Hosts, or rather, human beings."
Okay, so this is why these bioactive biomaterials are working in the bones, and it's the same. It's because these biomimetics are going to do the imitation of the remineralization, and this is called bio-remineralization. So these bioactive biomaterials, the most important thing is that are bioactive, that stimulate the regeneration, of these tissues with these special materials. Okay, so we can use these bioactive biomaterials in minimal invasive dentistry, and we're going to have good results in our treatments. For example, what happened in enamel? Enamel, we have prints. The prints are formed by hydroxyapatite crystals, and the crystals are formed for calcium and phosphate ions. Okay, when it's development, the enamel, we have this principal cell that is the enamel, that is the ameloblast, and the ameloblasts are going to synthesize a protein called amelogenin. These amelogenin are going to do the transportation and regulation of the calcium and phosphate in the organic matrix, and these organic matrix are going to crystals and form the hydroxyapatite crystals and start the mineralization of this tissue. Okay, when it's mature, this tissue, the ameloblasts are going to degrade these proteins called amelogenin, and then the ameloblast is going to disappear for the enamel. So in a mature enamel, we're going to have 97% of hydroxyapatite and only 1 or 2% of this protein that's its amelogenin. Why I am talking about this amelogenin? Because it's important, because this little percent, this only 2%, is stayed in the mature enamel in the interproximal prismatic zone. And when it's contact with the calcium and phosphate that come in from the saliva, they crystals and form the new hydroxyapatite crystals for nature remineralization. So it's important in bioactive biomaterial that this bioactive biomaterial give to the enamel calcium or phosphate. In the case of the new glass ionomers, strontium works as the same as the calcium. So we're going to have great for the bio-remineralization, this new generation of glass ionomers, because they have strontium, okay, that is the same and better than the calcium. In dentin, how is the bio-remineralization? Okay, the cell is the odontoblast. The odontoblast is going to form calcium and phosphate ions, and it's not going to have only one protein that is amelogenin in enamel. We're going to have a lot of proteins in dentin, and will help to form the hydroxyapatite crystals, because we are going to have more organic zone, so it's going to be great. And for mimic and for bioremineralization, it's perfect, the dentine, because we have more kind of organic matrix than the enamel. So what kind of materials are biomimetic? This is the bioactive biomaterials that helps to the biomimetic. We have three families: the nanohydroxyapatite, the enamel proteins, and the bioactive glass. Today I will talk about bioactive glass. The bioactive glass, okay? You maybe listened about the MTA. The MTA that was approved the FDA in the 1998, and this is the first bioactive glass biomaterial, okay? The first MTAs are the Prurut and the Angelus, but today we have a new generation of bioactive glass that these materials don't have bismuth. So this why are different from the first MTAs. This is the new generation. So how is work? How works is bioactive glasses? These bioactive glasses like the NeoMTA, Biodentine, or this new generation of glass ionomers with the Strontium. How works in the dentin and why this kind of material are bioactive biomaterials? I will explain to you with this video. Look here, this is the collagenous fibers. The collagenous fibers are so healthy, intact. When you apply a bioactive glass, for example, an NeoMTA or Biodentine, you are applying calcium. But when you are using a glass ionomer with a strontium, you are applying a strontium. Both calcium and strontium are going to work at the same. You are going to give a lot of this calcium or strontium minerals, so the pH of this zone is going to be alkaline and kills any bacteria that it's in this tissue. So you're going to be sure that your affected dentin is not going to have bacteria. After you saturate with this calcium or strontium, these are going to wake up the proteins, and these proteins are going to wake up the odontoblast to start to form again calcium and phosphate ions. These are going to transport the proteins to the collagenous fibers, and these collagenous fibers are going to crystals and form the new hydroxyapatite crystals. This is why these bioactive biomaterials like NeoMTA, Biodentine, or these new glass ionomers with strontium are mimic the Bio-Remineralization. So it's perfect for the treatment of the dentin, for reactionary dentinogenesis, or for repair dentinogenesis. You're going to do a great bioremineralization with these materials. And look this case, because it's easier to talk to you and say, oh, this is fantastic, but I want to show you cases to you can see that why I'm talking when I am referring about bioremineralization. Look this second primary molar. Look here. What was the diagnostic of this second primary molar? Maybe reversible pulpitis, but it's not. The diagnostic was necrotic pulp with internal resorption. So in this case, what is the option? Extraction. But if you extraction, you're going to lose the space. So I prefer to save the molar, and I did a LSTR pulp therapy with this triple paste that it's metronidazole, ciprofloxacin, and minocycline. And I did like a pulpotomy. I opened the pulp chamber. I applied the triple paste for 3 to 7 days, no more. And then in the second appointment, I removed this triple paste and I applied a bioactive glass. Look the repair of the lesion in the time. In 9 months, it's repaired the internal rubber resorption. 80 months, still everything working well. Look here, 20 months, the first permanent molar is perfect. And after 30 months, everything is perfect with the second primary molar. So this is biomimetic. This is how the bioactive biomaterials are mimic the nature doing bio-remineralization. Okay, look, this another case. We have this patient came to my dental office. This patient of 6 years old, and the mom was so worried because the other pediatric dentistry spent like 4 appointments trying to save this first molar, primary molar. And the mom said, oh, I prefer extraction, but my other pediatric dentistry, he doesn't want, so please do the extraction. So I said, please, I'm going to take an x-rays. And look here, the roots are perfect. So I said, please give me 2 appointments. And the mom was like, not sure. So I did with this patient LSTR pulp therapy, the same that in the other case. And look here, 6 months follow-up. Repair, regeneration of the lesion. 80-month follow-up, everything great. 30-month follow-up, start the first premolar eruption. And 30 months follow-up, the mom said, oh, I'm going to move to Barcelona for living, so please do the extraction. So I said, no problem, because it's coming the first premolar. Look here, I did the extraction, the premolar is there, and look how is okay, look here. How is the sealant of a bioactive biomaterial. This is perfect, and helps to us for regeneration, the lesions. Look, this is another case that I used nail putty, that is another bioactive biomaterial in a necrotic pulp. Look this. I did the same, the triple paste. After 5 days, I removed the triple paste. I applied the nail putty. Look here, after 1 month. No fistule. Look the x-rays, it start to repair. And after 9 months, look here, it's perfect. It's perfect because this patient is receiving orthodontic treatment. So this patient, you don't need to lose any space. No? So it's perfect. The better space is the teeth. What's the problem with some bioactive biomaterials like MTA or the neo-MTA or the biodentine is that it's not a definite restorative. So you need to use a restorative, okay, to apply in these materials. So for this, for the neo-MTA and from the biodentin, the best restorative material is the glass ionomer with the strontium. I will show you this case that I did a direct book copying. Look here, this first primary molar. Look here, pulp expulsion, the neo-MTA, and immediately I apply the Rivalite Cure High Viscosity. And why it's great to use it, this Rivalite Cure, this new generation of glass ionomer with the strontium, because this Rivalite Cure doesn't need to use polyacrylic acid. So it's perfect because neo-MTA, if you apply an acid, it's not going to work well. And in the Rivalite Cure, you don't need to apply polyacrylic acid. You only need to apply the Rivalite Cure, photopolymerization, and that's it. It's like we are looking in this video. Pulp expulsion, applies the neo-MTA, in this case the neo-party, and immediately the glass ionomer with the strontium, that is the Rivalite Cure, and the lesion is class 2, so I prefer to use it the high viscosity. Look the control 1 month, everything is perfect. And 6 months, everything is still working perfect. Okay, I'm going to talk more about this new generation of glass ionomers that have strontium, okay? Why is the difference? Why all this presentation I am telling strontium, strontium, strontium? Because the strontium is what the glass ionomers needs to have good, successful, and works great in effective denting. Do you remember that the glass ionomers need accounts of calcium? So with this new generation with the strontium, you don't need the calcium of the effective denting. The calcium, it's right now the strontium that have these materials. So the strontium will go into interaction with the fluoride and form strontium fluorapatite crystals. Look here, this is the strontium. The strontium has the same characteristics of the calcium. Why? Look the line of this chemical table. Calcium, and here is strontium. It works as the same. The strontium regulates perfect the osteoblasts and the odontoblasts, and is bacterial seed too. It's perfect. It's the perfect substitute of the calcium to form hydroxyapatite crystals. Look, the crystals are good crystals, bigger crystals for remineralization and bioremineralization, and this strontium can be a perfect synthesis with the fluoride and form the strontium fluorapatite, that it's higher susceptibility and it's more resist to the attack acid than the fluorapatite. Look here, this is why the glass ionomers with the strontium works in the effective denting.
It is essential that the glass ionomer is placed while it has a glossy surface. The gloss is free polyacid, which is able to penetrate the cavity surfaces to form a strong, hydrolytically stable chemical bond to calcium ions within the dentin and enamel. In addition to chemical adhesion to calcium in the tooth, a fusion bonding process takes place as well. Calcium and phosphate ions from the polyacid-treated dentin and enamel, and strontium and fluoride ions from the unset glass ionomer intermix and precipitate, forming an interface called the interdiffusion zone. This zone is stronger and more acid-resistant than either the glass ionomer or the tooth. The combination of the interdiffusion zone and the chemical bonding provides the basis for a strong, stable adhesive interface and creates a bacteria-proof seal for the cavity, best described as a chemically fused seal.
So that this works, and we have a strontium, 50% of strontium in the Riva glass ionomers, because we have this ion glass that have 50% of glass ionomers. That works great for the Bio-Remineralization. Look here, you have here the Riva Light Cure high viscosity in these capsules. It's so easier to use it. The Riva Light Cure with that is glass ionomer with resin, it's perfect. It's less growth of the biofilm, and it's easier to apply. Look here, I removed the infective dentin, and after I remove the infective dentin and I have the perfect effective dentin, I immediately apply the Riva Light Cure high viscosity. I don't need to use the polyacrylic acid. I don't need to use nothing. Applies direct the Riva Light Cure, then photopolymerization for 20 seconds, and that's it. You don't need a coat, you don't need nothing. This is a perfect restoration. And looks how is the sealing, perfect sealing. Look, this is another case, a follow-up of 24 months, and the sealing is still perfect with the Riva Light Cure high viscosity. This is another case that I used the Riva Light Cure high viscosity. Perfect, perfect seal. And this is a case for an adult. This case, look here, is a patient that have a root canal treatment, and you need to do the reconstruction. And I did the reconstruction of this lesion with the Riva Light Cure high viscosity, and it's still 50-month follow-up. Look, it's perfect. That's the reason that right now I'm not going to use the steel crowns in pediatric dentistry or in proximal caries in pediatric dentistry, because the Riva Light Cure high viscosity resists so good the occlusion forces. Okay, if we have caries lesion in enamel, I prefer to use only the Riva Light Cure because it's more flow for pit and fissures, lesions. In this case, I not remove the caries, I only clean the biofilm, and then I apply immediately the Riva Light Cure. Why I'm sure that it's going to work? Remember that in the interprismatic zone, we have these proteins called amelogenin, and when it's going to be in contact with the strontium, that is the same as calcium, is going to start the Bio-Remineralization of this lesion. And in molar incisor hypomineralization, these glass ionomers with the strontium works great. For example, Riva Protect, that is a glass ionomer sealant. If you have, for example, this case that you have an MIH and you don't have problems that it's broken enamel, that is intact enamel, in this case you can use it, a Riva Protect like Cure, to protect these pit and fissures with MIH lesions. And look, the follow-up, 24 months, and works perfect. And high viscosity, I use it in this case that I have MIH and dentine caries. No? Look here, perfect sealant of the lesion with the high viscosity. And do you remember that I told you when you are close to the pulp, don't use the SDF because you have the risk of the high penetration of the silver. We know that the silver is the best bactericida and kills all the bacteria, and it's so important. Look here, we have right now a glass ionomer with a strontium and silver. This is the Riva silver. This Riva silver, you can use it when you are so close to the pulp. For example, in this case, look here, this first primary molar with this caries lesion, look the x-rays, secondary caries. So I remove the lesion and I apply the Riva silver. After 1 week, I remove the Riva silver from enamel, and I am doing the restoration, the aesthetic restoration with the Aura composite. Look here, perfect. And the control follow-up 9 months, everything is working well. And at the last, that SMART technique. Do you remember that I talked to you that the SMART technique for doing in enamel and the silver modified atraumatic restorative treatment? So who is going to be the best glass ionomer for work the SMART technique? These glass ionomers with the strontium, and you can use it in MIH treatments. So if the patient don't have any problem that we stain a little bit, you can do it, because remember that the SDF is the best in control hypersensibility. And in these cases, the patient has hypersensibility. So you can use it, the SDF, for control the hypersensibility, and then do the SMART technique, applying the glass ionomer. And in this case, the best glass ionomer are these glass ionomers with strontium. And you can use it, the Riddle-Light Cure high viscosity, to have more resist from the occlusion forces. So this is another alternative for the treatment of MIH in the case that you have hypersensibility in your patients. Thank you so much for being here and listen these presentations. So I am open to any questions. Celeste?
Thank you so much, Dr. Rocio. Are there any questions? I know there's one question. I'm just putting it out there.
Sorry.
Question. So the question that's currently on the board: is there no possibility of silver absorption into the blood system? Any systematic side effects?
Sorry for the question, please.
Sorry, I think the signal. Is there no possibility of silver absorption into the blood system? Any systematic side effects?
Can I read the question, please?
Michael, I text you the question. Silver absorption into the blood system. In other words, are there any systematic side effects? What I will do is I will get the answer to that question, and then I will email Dr. Nzama the answer. Hi, Michael.
Hi, Michael. Oh, okay, into the blood. Okay. Okay, the silver, okay, have the problem that the SDF has the problem that it's penetration. It's a high penetration. So that's the reason that I said that I prefer to don't use SDF that has a high penetration so close to the pulp, because you have the problem that this silver necrotic the pulp. Your question is about the blood, that if you have maybe some problems, it's not toxic. This the research that are investigate that this SDF it's toxic from the human. No, it's not toxic. Don't be worried. Be worried only with the pulp, because if you are using the SDF so close to the pulp, maybe you can necrotic. But don't worry about the blood. You are not going to be any toxic. No toxic material is the SDF from the human blood. Don't be worried about it.
Thank you, Dr. Rocio. Dr. Rocio, can you hear me?
Yeah.
Okay, the next question. Neopathy. Can it be used for direct and indirect pulp capping in adults and children?
Exactly. In adults and children's, you can use it, the nail putty. The nail putty is a bioactive glass that it's calcium, tricalcium, and it's work perfect in indirect pulp capping, in pulpotomy. So it works in primary and in permanent teeth. You're going to have great results. So I'm using in both cases, in primary and in permanent.
Thank you. When using Neopathy and then Riva to restore, do you just place the Riva directly over the Neopathy, or do you first etch and bond and then place the Riva?
No. What's happened? All these kinds of bioactive biomaterials like Neopathy, Neo-MTA, you don't need to use orthophosphoric acid or polyacrylic acid. Please don't use it, because these materials need water, and if you are applies orthophosphoric acid or polyacrylic acid, you are going to deshydratation of the material, and the material is not going to work well. That is the reason that the best material is these glass ionomers with strontium, because this glass ionomer with strontium, you don't need to use polyacrylic acid. So the Riva Light Cure high viscosity, you don't need to apply any acid, polyacrylic, orthophosphoric, any acid. So this is going to be perfect, the adhesive to the nail putty, and you will have great results in your restoration.
Thank you.
You're right.
Can STF be used for interdental caries in adults without using separating elastics but floss? But with just floss?
Yeah. In adults, works perfect. It's the same. When you have any lesion in enamel, works perfect the SDF. No? I prefer to use these orthodontic separators, because sometimes you're not sure when you pass the floss that you are applying that one drop of the SDF. So I prefer to be so careful, to be so sure, to use these separations, orthodontic separates, elastics. So it's why my experience it's better, no?
Thank you.
You're welcome.
There's no more questions. So Dr. Rocio, thank you very much for a very informative presentation. And Michael from the company STI, thank you to all the delegates in this freezing weather with all the load shedding going on for attending this webinar. So Wright Milners is the suppliers of STI products for many years already. Products, for example, Riva, Stick Cement and Permite. This Riva Star is a revolutionary product. We're super excited about it. So all the delegates will receive all the information about this product, all the brochures, the recording link as well, and the promotions, the recording, the brochure, the product information, everything. And please note, we also do stock those smart burrs. Early in the presentation, you mentioned those phenomenal smart burrs. Wright Milners also supply those smart burrs. So thank you very much to everyone.
Thank you. Thank you, Yolanda.
Thank you, Dr. Rocio. Thank you to the delegates. Thank you. Have a good evening.
Thank you so much. If somebody wants to ask me more about minimally invasive dentistry, how to use it, the SDF, or about this new generation of glass ionomers with the Strontium, like Riva Light Cure, high viscosity, and the other Rivas, you can write to me a message to my Facebook, and I'm going to be glad to answer any question.
Thank you. So when they receive all the email from us tomorrow, they can put all the technical questions and we can forward it to yourself and Michael.
Great. Thank you so much.
Thank you, everyone. Goodbye.
Goodbye. Have a good night. Bye-bye.